The big picture, as we all know, is inflammation. As Dr. Bale and Ms. Doneen have so expertly shown us, that inflammation is causal. It's a big event, and we know there are multiple factors, there are multiple red flags that are associated with systemic inflammation. We know too that, of course, periodontal disease is an integral part of vascular inflammation. We need to understand the concept of portal of entry, virulence, transmission, concentration, and how we treat individuals on a personalized basis. For those that are treating periodontal disease, we need to make sure that we have effective risk assessment and disease management. We have to be able to measure at a real-time experience to create a baseline. We have to be able to treat it effectively, and we have to be able to measure our treatment at the end of treatment to see if we are successful. One of the problems that we have in the research is that almost all of these patients that are treated for periodontal disease are treated only with scaling and root planing. And we need a model, as Dr. Bale said, that really shows whether our treatment is effective or not. And the only way we can do that is to have a baseline to measure, and then an after treatment to measure. Those of us who are on different medications for inflammatory issues or for hypertension issues, we routinely have blood tests, do we not, to find out if the medication is appropriate for our particular disease entity. If it is, we continue that medication. If it isn't, they either alter that medication or they change the medication. The same is true now with periodontal disease. We need to know if our treatment is in fact effective. So let's define periodontal disease based on a real workable definition, something that we can understand and something that our patients can understand. And as we look at all of the definitions of periodontal disease, they ultimately center around these three components. And that is that periodontal disease is, first of all, an inflammatory disease. It is, secondly, caused by specific or groups of specific microorganisms that result in the destruction of the gingival tissue and all of the supportive tissues associated with holding the teeth in the alveolar process. And the third component is that periodontal diseases, in particular periodontitis, is considered as a complex genetic disease whose phenotype is affected by both the genetic makeup and the environmental influences on the individual. Now, as we look at this definition, we need to make it very usable. And this is where we are today in our understanding of periodontal disease. In 1998, two biochemists, Drs. Barthold and Narayanan, wrote a textbook called The Biology of the Periodontal Connective Tissue. And they said there were 4 events that were associated with the development of periodontal diseases that you see here. Now, what I want to do at this point is to ask the question, when we are diagnosing periodontal disease today, where are we in these 4 stages? Because we're going to talk about every 4 stage. Are we here, are we here, are we here, or are we here? Based on the profession, not based on your practice itself, but how do we measure periodontal disease today in the profession? Bone loss. So this is where we are in the profession. It's pocket depth. It's all about radiographic bone loss, or it's about using the probe. We're using an archaic tool called the periodontal probe to measure a very serious disease. Now, the point that Drs. Narayanan and Barthold stated was that all periodontal diseases, including gingivitis, begins with a bacterial infection. The second point that they make is that there is an inflammatory response and that all individuals are affected and influenced by their own genetics. And of course, there are epigenetics that are involved in the process. So there is a series of events that occur before we end up with pocket depths. So if we are going to relate to the new definition of periodontal disease and to the events associated with periodontal disease, wouldn't it make sense, and I would suggest that we consider that this is, in fact, end-stage disease. As we are looking at heart attacks and strokes and diabetes, as Dr. Bale and Ms. Doneen would tell us, is that the development of diabetes is an event process. It takes 10 to 20 years to be full-blown diabetic. The beta cells have to fail a long period of time before you end up with diabetes. And so I would suggest to us that periodontal disease is the same. And we are measuring end-stage disease, not early disease. And in order for us to really appropriately apply this information, we need to start looking at early disease, or those that are at risk for disease. As an example, the 5-year-old that was made reference today. I have seen through our laboratory 7-year-olds losing bone in their first permanent molars. I've seen 12-year-olds in braces. I've seen 19, 17, 18, 20-year-olds that have risk for periodontal disease, or they actually have periodontal disease. We now have 3 cases, 3 years old, 4 years old, and 5 years old, that are losing alveolar bone around deciduous teeth. And they are infected with these microorganisms. And of course, as stated there, where did they come from? They came from their parents or their grandparents or whoever their close relatives are that care for the children. So the real point that we are relating to is, if we're going to define periodontal disease, we have to define it at an earlier point in time if we are really going to affect vascular health. In fact, as we put this here, when does arterial exposure actually occur? It's going to vary from person to person based on all of these events: bacteria, inflammatory response, genetics. And we don't have to wait for end-stage disease to consider the fact that arterial exposure is probably occurring during this whole process. Therefore, end-stage disease, we know, creates arterial exposure. But what about here? When we have specific bacteria that may create arterial exposure before we have bone loss. And that's what I'm going to show you. We're going to show some histology of all types of periodontal disease and the potential that individuals are infected with these microorganisms, that are infected with these microorganisms, may actually have portal of entry into the circulatory system prior to end-stage disease. So we want to look at the effect of arterial exposure on the inflammatory effect of endothelium. And so we ask the question, how do we measure that? So do we only measure people that have end-stage, in other words, type 4 periodontal disease, or do we start looking at all of these events and determine if they have serum markers of inflammation at any point in time in the periodontal event experience? Everybody with me here? We don't have to wait, because now we can know based on our ability to measure biomarkers of inflammation. So I would suggest to us that while all the studies clearly show that type 4 periodontal disease increased risk for all these systemic conditions, is that if we can prevent periodontal disease earlier, then we can take out the event of periodontal disease as being a risk factor for all of these others events that are associated. So wouldn't it be great? Of course, we have to treat patients wherever they are when they come to see us. And many of our patients come to see us with disease. And thus we have to define the disease, we have to treat the disease effectively, and then we have to monitor that disease process. So as we look at the joint consensus that was written in 2009 between the editors of Journal of Cardiology and the editors of Journal of Periodontology, we see that they discuss 2 mechanisms that are associated with the development of this relationship between cardiovascular disease and periodontal disease. And we want to talk about this for a few moments. Number one, they state that one mechanism is the spread of gram-negative bacteria that gain access to the circulatory system through ulcerated gingival tissue or through the lining of the pocket. So we want to look at access to vasculature. How is that possible? When does it happen? And suggest to you that it does happen more early than late. And we also want to look at spread of gram-negative bacteria. So we'll look at these very closely. It is true that the head is connected to the rest of the body. and that there is a circulatory system connected to the head and the mouth. So as we look at the large circulatory system associated with the head and neck region, and then we bring that down to the facial regions, we see very large arteries that are associated with providing blood flow on the facial surfaces, lingual surfaces, and through the alveolar bone. And we can see, of course, some of the small arterioles that are there in this slide. But more closely, let's look at an illustration of between teeth and also on the buccal surface. So as we look at the alveolar bone in cross-section, we see the larger artery coming through the bone, branching out into the small arterioles, and of course a very highly vascularized area of tissue, which we of course know exists. So if we look between the vascular system and the epithelial tissue, there is a very, very short distance between the epithelium and the vascular system. So let's talk about portal of entry. This is a histology slide of an erupting tooth showing the gingival tissue and the epithelial attachment prior to completely attaching to the enamel surface. So we talk about portal of entry, and we sometimes think portal of entry just because we get subgingival plaque or calculus down in this area here, but really portal of entry involves this very delicate epithelial tissue here that is designed to protect, of course, our skin, whether it be oral mucosa or whether it be stratified epithelial tissue on the rest of our body, is the largest protective organ in and on our body. So this very, very vital skin, very, very thin skin is what protects us from vascular entrance of these bacteria. Now I show this illustration to talk about biofilm because we need to understand that biofilm differs in a lot of different ways. So when we look at the tooth surface as illustrated here and the gingival, free gingival tissue here and then supposedly the epithelial attachment, we see that there are three basic areas of types of bacteria. Some have an affinity to the tooth surface, and thus the biofilm connects to the tooth, and that's where we spend all of our time, right? Is cleaning the teeth. Subgingival debridement of these biofilms here. We know they also have a free-floating area of bacteria that are called planktonic bacteria, and then we also have a series of bacteria that can penetrate tissue even without a break. In other words, they create their own portal of entry. When we have a true portal of entry, meaning that we've lost the epithelial attachment and then everything can fall in there, then that's what we're treating. But what I want us to impress here is that these bacteria can penetrate tissue without losing the epithelial attachment. So when we have chronic gingivitis, I would suggest to us that bacteria are penetrating the epithelial tissue and the endothelial tissues long before we have epithelial attachment lost. In fact, here's a histology slide clearly showing a very, very secure epithelial attachment, and these are bacteria that are found in this artery right here, and there's another artery that goes here. So even in not lost epithelial attachment, we can have bacteria penetrating. And as was suggested here, some bacteria have a greater potential based on their virulence factors and the pathogenic capability to penetrate tissue. Yes? What mechanism do these microorganisms have to get through the tissue? Well, let's go a little further and let's see if we can understand that. So let's look here at a healthy individual. One of the photographs is one of my oldest son, Tommy, who's with us here today. And he is very involved, was involved in the development of our company, but is also very involved in treating periodontal disease and in lecturing about that. But when we look at this tissue in a healthy individual, then we have the epithelial attachment, we have the gingival attachment here, and then everything is working very nicely. But look what happens even when we have an early lesion, an early or initial gingivitis. We can see this based on our clinical signs, but what we are seeing here is that we're starting to see some changes. This is certainly early disease. How do we know that? Because when we look at the inflammatory mediators and the microbiology, we begin to see 3 alterations, even in early disease. Microbiological differences, anatomical difference, and physiological difference, including vasodilation, angiogenesis, prominence of plasma cells, all of the innate and the acquired immune responses, including the immunoglobulins in connective tissue, and increased sulcus exudate. And interesting too, if you remember from Dr. Bale's presentation here, we have all of these cytokines, matrix metalloproteinases, including IL-16, IL-11, tissue necrosis factor, matrix, myeloperoxidase. I put MPO here, myeloperoxidase, and the matrix metalloproteinases. So we begin to see very early some major immune responses occurring in these tissues, including invasion of these microorganisms. To answer your question, they break down the intercellular junction between the epithelial cells and also the endothelial cells. So we know there is intercellular invasion, meaning that they can invade between the cells. They destroy the collagen between the squamous cells, and they just bore right on through there. And then the second thing that they do is many of them have the ability then to, like FN is presented today, they have the ability to interrupt the juncture mechanism between the endothelial cells and actually penetrate between endothelial cells, or actually penetrate the cell. They have the ability to do that. So as we look at the immunological changes that are occurring, we see that it occurs very early as opposed to, and of course it occurs late, but it occurs for a long period of time.
Hey Tom, can I interrupt you real quickly? I just want to make a point here. If you can go back to your previous slide, the one before that. If you, as a hygienist and a dentist, were to take this information to your GP down the street and say, did you know that when you look in your patient's mouth and you see the very early signs of, explain to them what they would see clinically here, and ask them to work with you and identify yourself. Say, I am an expert on understanding the relationship between these early signs of periodontal activity and what goes on systemically with the body. I'm an expert in that, and I want to work with you. This is a great slide just to show that very simplistic point. Absolutely. And the medical providers can understand this, and they get it. So that may be one form of communication.
Thank you. I do appreciate that, because you can clearly see here the changes in the junctional epithelium, and then you can explain all the cytokines, matrix metalloproteinases, and so forth that are associated with that. So how important is bleeding on probing? If you notice, I'm spending a lot of time on early disease, because we are experts in late disease. And we need to become experts in definition of early disease and treatment of early disease, just like as we are hearing from our experts here in the cardiovascular field. They are experts in early disease, and we need to become experts too. So as we look at this particular study, that is part of the INVEST study. It's very interesting. I hope you get a chance to read all 3 INVEST studies. It's called the Oral Infections and Vascular Disease Epidemiological Studies, or INVEST. There was one in 2005 that was referenced today that had to do with changes in the CIMT. This is a follow-up study from 2008, and then the 2010 study looked at specific bacteria and hypertension. But this is a great study for every dentist, for every hygienist, oral surgeon, endodontist, orthodontist, whatever, because it shows the importance of early bleeding. What causes early bleeding? Well, this is what this study is really designed to show. It looked at over 700 subjects and almost 5,000 samples. And what they tested for were 11 bacteria with quantitative assay. In other words, they looked at the same bacteria that happened to be on our report, your report, the report that you're using. And they called them etiological burden, meaning those that cause periodontal disease and cause the attachment loss. They broke it down to putative burden, meaning those that we call moderate risk pathogens. And then they did something unique too. They took 2 health-associated and called it health-associated burden. And these were the two microorganisms that they used in this. This is really, really important because they looked at all of these bacteria in individuals that had 1 to 3 millimeters or 0 to 3 millimeters pocketing. And they wanted to find out, does the pocket precede the establishment of the subgingival profile, or is bleeding on probing established by these bacteria actually cause bleeding? Everybody understand there? Which comes first, the chicken or the egg? Does bleeding come first and pocket depth, and then does the pocket depth create an environment that establishes these high-risk bacteria, or do the high-risk bacteria actually come first and establish an environment that breaks down the connective tissue? This has been an area of debate for decades, and this study helps us to explain why treatment of early disease is so important. When we see chronic gingivitis as an example, it is a disease, and this shows why it's a disease. So when we look at the prevalence of bleeding on probing broken down into level of subgingival colonization, that's dose or concentration. That's the black line that you see on the report. Everybody get this? So when we look at levels of bacteria of these classifications, look here. And this particular one right here is the EB, or etiologic burden, the high-risk bacteria. So when there is very low burden, you do get about a 15% bleeding on probing based on full mouth. So you, even at very low concentrations of these bacteria, everybody following me here? So if a person has very low concentrations of these bacteria, they will get bleeding. Look what happens in quartile 2 when the concentration of the bacteria go up. Look what happens in quartile 3. And when we have the highest concentration of these bacteria in 0 to 2 millimeter pockets, everybody get it? Bleeding is caused by bacteria, and especially these bacteria. Now look what happens when we look at what is called the putative burden. Interesting enough, and I'll show you some of our laboratory data too, there's more bleeding initially at low concentration on the orange complex. Interesting. We don't see as much attachment loss with these bacteria, but we do see bleeding earlier in low levels of orange complex bacteria than we do red complex. But look what happens to it. It levels off. So we end up with the highest quartile of about 45% of the mouth bleeding when we have those moderate risk bacteria. But look what happens when we have a concentration of normal bacteria or health-associated bacteria. If it gets concentrated, yes, we can have bleeding, but it becomes, the concentration is not that significant there. It's the etiologic burden and the pathogen. Now look at pocket depth. When we look at the prevalence of bleeding and the mean pocket depth based on bacteria, and this is how healthy these individuals were. The deepest pocket depth they found was 3.6 millimeters in these particular studies, of these large studies. So pocket depth based on high-risk bacteria goes up exponentially based on concentration. Pocket depth based on moderate risk goes up, but not as high, and pocket depth of these never gets more than 3 millimeters. The point here is we need to understand when we have patients that have chronic gingivitis what the bacterial burden is. If we can define the bacterial burden early and treat it early, we will not have attachment loss. Any questions on that? Does it make sense to you? So bleeding on probing, it should be a red flag. And we should treat chronic gingivitis as a periodontal disease, not as a prophy, in my opinion. Yes? Yes, that's right. Yes, right. Yeah. Yeah. That's a great statement, and I know that is in the back of everybody. And let me just say, we're going to have a guest speaker at the end of the day. It's really a bonus, and that the guest speaker is going to address how we can, it's Steve Anderson here. Steve is going to talk to us today about how we can kind of get over some of those hurdles. But I understand what you're saying, because if you don't have pocket depth that you can show and so forth, they're not going to pay for periodontal treatment. I understand that. So, yes, another question.
How much does other medications that patients
yes, yes.
affect bleeding out?
Yeah, great. Absolutely. 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 How much does medication? Absolutely it does. So certainly low dose aspirin, it's 81 milligrams of aspirin will increase your bleeding.
So how do you filter it out?
How do you filter it out? Well, you certainly ask the questions, are you taking? Yes, absolutely. Right. Yeah. 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 Well, the question is, once we treat and we get our pathogens low and they still have bleeding, is that your question there? Yeah. What do we do? Well, are you looking at nutritional options as far as treating them as well, along with the antimicrobial? And so maybe there are nutritional, problems that we need to be dealing with, and some patient-to-patient, problems. Certainly, we do need to delve into those areas as well. Now, I show this, and it's not in your book, but this is unpublished data, and this is greater than 16,000 subjects of individuals that we've tested, and it proves the point. And let me just say this, of those that are testing that are across the country, the average pocket depth that is being tested is 6 millimeters. We are testing late stage disease, not early stage disease. Now I know there are exceptions to that, but I'm looking at, let's say, 50,000 to 60,000, and the average pocket depth is 6 millimeters. Some it's deeper than that, some is shallower than that, but the average pocket depth is what I'm talking about.
The average pocket depth, you mean the worst pocket in those patients is 6 millimeters?
It's the average based on the entire mouth and based on what we're seeing. We get 6, for those that you are filling that out, we get 6 pocket depths per patient when you fill that part out. And so we take those 6 pocket depths and we look at these thousands of cases and we give an average. So maybe you're sending us a 5 and a 7 and a 3 and an 8, but that's going to average out over these thousands of cases here to be 6 millimeters.
I understand the form because I'm filling it out.
Good.
I guess my question was, still the majority of those pockets in those patients.
That's correct. That's correct. I see what you're saying, yes. But based on the information from these 6 sites that we are getting, the average pocket depth is 6. So what does that mean? So if you go to 6 and look at concentration of all of these moderate risk bacteria here, you see a much higher dose of bacteria in these pockets. Why? Well, patients can't clean that far. And of course, we have a great environment for these continue to multiply and so forth. But what the point here, based on bleeding and probing, is yes, even in 1 millimeter pockets, we find bacteria of this type. And the same thing is true in high risk. Even in 1 millimeter spaces, individuals that have periodontal disease can have these bacteria. And you understand the point here? So we can look at it 2 ways. Deep pockets, shallow pockets. We just simply know that these bacteria are associated with bleeding. If we look at A and PG, this is a slide I created some months ago because it clearly shows in greater than 16,000 subject samples, unpublished data here, as we look at below threshold and above threshold, the average individual, there's only about a 12% of your patients that actually have PG infections. That doesn't mean they don't have periodontal disease, though. So as we talk about AAPG and risk for systemic disease, systemic for inflammation, we don't want to leave thinking that everybody that has periodontal disease is going to end up with a heart attack. And we don't want to say that. Everybody's risk is different. And we have to know what their risk is based on our clinical signs and based also on these tests. So it's information that we are discovering and have discovered based on the infections. So gingival inflammation in high-risk subjects, smokers, diabetics, heart disease, people that already have recognized heart disease, interleukin-1 positive genotypes, and those who do not respond to therapies. Nice article written by a former president of the AEP, published in 2008, talks about more aggressive therapy, reducing recall intervals or shortening them, reinforcing home care techniques, recommending certain essential oils, toothpaste, and so forth, and even prescribing local delivery drugs, systemic antibiotics, or subantimicrobial dose doxycycline. Of course, be sure that you test all of these patients regardless of pocket depth to make sure where they are. So we ultimately end up with where most people are treating periodontal disease today, and that is individuals that have 4, 5, 6 millimeters of pocketing. And when we look at these individuals from a histological standpoint of view, we see, major changes in the vascular system in that particular area. Now, we know as dentists the relationship, and our physician colleagues are learning this too, there is a relationship, bidirectional relationship between diabetes and tooth loss and severe periodontal disease. And this is really event reality. When we look at these individuals that have these types of bacteria and systemic diseases, they are at increased risk. So a physician can see this, so when they are looking in the mouth, they certainly should be looking for these types of signs of inflammation. This is event reality also when we are looking at bacteria, and we should be looking at bacteria. This was a case that was published in 2010 in JADA. They did not tell us what the infection was other than the fact that it's a polymicrobial infection. And this is the patient. He had a single abscess tooth, and he was uncontrolled diabetes, or diabetic, which is A1C of 11.5. He did not take the medication that the dentist had prescribed for the acute infection and did not go to the oral surgeon. And he ended up in ICU for 34 days. The good news is the patient survived. Many patients do not. Is Dr. Forrest in here, Dr. Forrest Bale? Dr. Bale, how many times do you see patients like this in a year? A couple of times. It doesn't happen often, it does happen, doesn't it? I'm sorry? Yeah. But the point that we want to say is these bacteria that you guys see on a day-to-day basis create bad events. So here he is on day 6, here he is on day 9, and here he is on days 10 through 14. The infection has literally gone down his neck into his chest, and this patient did survive from a single tooth infection. This is event reality also. This is cavernous sinus thrombosis. We all learned about it in school, and this is oftentimes caused by Actinobacillus actinomycin incompetens. And the survival rate is pretty small with these. They can go downhill extremely fast. And another way of saying it is that the mortality rate is 60 to 80%. So these microorganisms that are in the mouth, when they have portal of entry, are critical and even dangerous just from the head and neck regions, not even including what we've been talking about. So what do we do differently? So what have we learned throughout the past 2 decades about specific microorganisms and risk? Risk assessment is an important part of medical care today, including what all of us do. And that is when we look at this subject, this particular article of 938 subjects looking at 6,900 sites, what they found was a linear association of detection of level of bacterial species and probing depth greater than 5 millimeters. This correlates well with bleeding on probing and the other literature because when they found individuals that had greater than 5 millimeters, they found P. gingivalis being a risk factor or an odds ratio at 4 times higher than those who didn't have. The AA was 3 times higher, the EC was 2 times, or 2.7, and the FN was 2.8. We've known that for almost 20 years. So if you want to assess risk, and you should be, in fact, I would suggest that you look at anybody very early rather than late. So if you have a patient that has gingivitis and you do a prophy and you ask them to do certain home care things and you're concerned, get them back in 3 months, not 6 months or 2 months, whatever you decide to do, and then look at them again and either test them on the first appointment or at least test them on the second appointment to find out where they are. Because patients that have chronic gingivitis certainly need to be tested. Yes? Cumulative effects of all of these? Yes, there are. So I'll show you. The question is, are there any studies on cumulative effects? So there's 2 things. There's the cumulative bacterial burden of all of these, and then there's also the synergistic effect of specific microbes that come together. I think I'll have time to show some of that today. This is another study from 2006 that was published to clearly show how important concentration or dose is. So when we look at a person that is infected with P. gingivalis at greater than 10 to the 5th, their relative risk for losing 2 millimeters of bone is 2.2 times versus those who don't have PG. If you move that up 1 log to 10 to the 6th, their relative risk for losing 2 millimeters of bone is over 4 times greater than if they didn't have that microorganism. So if you're looking at risk, ideally you would want to know this before they had bone loss, wouldn't you? Or if they had a 4 millimeter pocket and you knew this, you'd want to know this. Because if they leave with this microorganism, then over the next few months they're going to lose 2 millimeters of bone based on this relative risk. So we need to look at things other than clinical signs, as has been stated today. There are no clinical parameters that can predict bone loss other than certainly certain health issues and very severe disease. But monitoring certain specific pathogens can do that. And I think this is one of the last slides that I want to show on early disease. And I hope you get the point that we need to change our model and start looking at early disease. So what about gingivitis and interleukin-1? You've heard a considerable amount about the interleukin family, IL-1, IL-6. And they did this study, and what they found out is even in gingivitis cases that IL-1 was 2.6-fold increased, let me say it again, that in gingivitis patients, there was a 2.6-fold increase in interleukin-1 beta. Go back and look at some of the literature that Dr. Bale showed you about the importance of interleukin beta to correlate that. There was also a 3.1 increase in interleukin alpha in gingivitis, again. So why is that important? Because it ties in to leukocyte adhesion to the endothelium, being an essential element in inflammation and pathogenesis of vascular disease. So when you have gingivitis and IL-1 expression, how does that change leukocyte adhesion? By 18.3-fold. Leukocyte adhesion is monumentally changed when there's that kind of infection. In fact, when we looked at the IL-1 genotype, and many of you have seen this slide before, and versus coronary artery disease, we find that the IL-1 positive patient is at increased risk over cholesterol, lipoprotein A, and is equivalent to a full-time smoker in a non-smoker for having coronary artery occlusion. So we can test. The point is, by looking at these early slides of early disease, is to simply say that any point in this event process of infection, inflammatory response, genetic response, ultimately ending up in what we call full-blown late-stage periodontal disease, we can test. The second mechanism that is associated with this process is endothelial injury. from the effects of circulating toxins, as was addressed earlier. We know that certain of these microorganisms, particularly A and PG, do have the LPS. We also know that both of these microorganisms can invade heart and aortic endothelial cells, and of course that's not a good thing. And we have learned that the endotoxin of P. gingivalis, or the LPS of P. gingivalis, is directly involved in the development of ASVD by stimulating atherosclerosis-related gene expression. And of course, this is significant because it ties in periodontal disease to atherosclerosis. We looked at FN earlier by other two speakers, so I won't mention that. But the result of looking at FN is important because it seems to be an enabler for other along for itself, but also for other bacteria to break through the endothelial barrier. This is an interesting study and a good one that was published in 2005, but it's still very, very good because it talks about the difference between clinical signs of periodontal disease and microbiologic signs of periodontal disease. A large population study in the atherosclerosis risk and communities group, and they looked at the clinical signs of periodontal disease in relationship to coronary heart disease and antibody studies to IgG. The results were that if they were infected with Treponema dinicola, their odds ratio was 70% higher that they would have coronary heart disease. If they had Prevotella intermedia or PI, they had a 50% increased risk. Cavernous ochracea, if you look at your chart, those of you who are testing, at the end it says CS, that's the Cavernous species. And that includes Cavernous ochracea, gingivalis, and sputagina. So there's 3 Cavernous species in the report. You just don't see it, but this is one of the ones that is measured in that report. A 50% increased risk. AA initiated a 70% increase. And when you add the two together, as was asked here earlier by a physician colleague, is there any synergistic relationship to? If we add AA and CO together, the odds ratio of having coronary heart disease is actually larger than any of the single combination of the microorganisms that are there. We certainly know that's true in periodontal disease too. There's a synergistic effect, but apparently there's a synergistic effect too, even in never smokers, of having coronary heart disease. So the conclusion is that the quality and quantity of the host response to oral bacteria is more relevant to systemic coronary events than clinical measures. So if we're just measuring periodontal disease based on clinical signs of disease, we're not doing a very good job of relating that to systemic heart disease. This study was published as an abstract. I don't have the full article on that. I haven't found it yet, but it was a study that was published in Sweden just a few months ago, looking at 8,000 subjects with periodontal disease. And these were the observations of this study. Individuals that had fewer than 21 teeth had a 69% increased risk for heart attack. They had a 53% increased risk for high numbers of deep pockets. They had a 2.5 increased risk of congestive heart failure with fewer teeth, and had a 2.1 increased risk for stroke against the incidence of highest number of gum bleeding. Now a couple of studies. Any questions at this point? Yes, question. Yes. Yeah, yes. Yes. What do I recommend on essential oils? I try not to recommend on things like that. Do you have something that you use, such as Closis and so forth? Yeah. I don't think there is any perfect essential oil out there. They'd probably be talking about Listerine and those types of essential oils. Certainly, I would definitely consider povidone iodine during treatment. I would also consider chlorhexidine during treatment. During treatment, I would double the strength of chlorhexidine, send them home with a 0.12, but I would have my pharmacist compound double strength chlorhexidine. You can have your pharmacist create a 0.20 strength chlorhexidine during treatment. You can't send that home with them for FDA reasons, but it's important, I think, to use a strong antimicrobial message and treatment strategy in the practice. So you might want to try doing that. Some of them, I know practices are doing that today. Are y'all compounding?
We have a compound. There's a national compound monitoring now.
Okay. So you can buy this, and maybe you can get with Tommy later and find out who that national company is, and you can use that in your practice and then send them home with the 0.12. Closest is another one, and so forth. Periprotect, yeah, certainly a good choice, for treatment. They have some really nice studies on their model, and it seems to work well. As Dr. Bale said, we haven't found maybe the perfect treatment for everybody. I think it's good to have different treatment strategies for different patients. Yes?
A good strategy to do is whatever the patient is doing is test them.
Yes. There you go. What Dr. Winnett said is exactly right, and that is you just simply test beforehand and test after treatment to find out if what you're doing is working. And if it's working, you stay on that regimen. If it's not working, you shift and change. So this is an interesting study that was just published in July of this year on all-cause mortality in periodontitis in a 60 to 7-year-old Western European group, and they looked at 1,400 men in this age group from Northern Ireland, and they divided the men into thirds based on periodontal attachment loss. And what is really so interesting about this case is certainly the deaths of the individual that occurred and the correlation to periodontal disease, but look at the pocket depths of these individuals. So 152 men died during this 8.9-year follow-up. 37 died with the lowest periodontal attachment loss. And look, this is an average loss of periodontal attachment in the full mouth periodontal exam. That's a pretty healthy individual, isn't it? That's a very healthy individual. But when we look at greater than 1.8 millimeters, 42 of the group died and 73 died when the average pocket depth was greater than 2.6 millimeters. That's incredible to me because we are not even treating, in most cases, individuals that have 2.6 millimeters pocketing. Right? And when you look at the groups together, the unadjusted hazard rate based on highest pocket depths to lowest pocket depths, the hazard for dying is twofold greater on the highest pocket depth, which is 2.6 millimeters, versus the lowest, which is 1.8. But when you adjust for all the other things, still the hazard rate for dying for these individuals was 57% higher because they had periodontal disease. They are Irish. Speaking from a real Irishman, is that correct? This is another really interesting study that just published in Diabetes Care in July, and that is periodontal infection, systemic inflammation, and insulin resistance. We've talked about inflammation and insulin resistance today, and in this particular study, it acknowledged the fact that we realize that systemic inflammation is known to predict insulin resistance and diabetes, and that periodontal disease is known to elevate systemic inflammation, and other studies have shown that periodontal disease can increase A1C over a longitudinal study for as long as 20 years and actually can predict diabetes. But the objective here was to see if periodontal disease may be related to insulin resistance among diabetes-free individuals. So they looked at 3,600 individuals in this age group of 20 to 85. They all received periodontal exam and fasting blood draw, and they broke the periodontal exam based on 4 quartiles: no disease, early disease, moderate, and severe. And then the relative risk was adjusted for multiple periodontal disease and insulin-resistant risk factors. And here is the chart. You might not have that in your handouts. Do you have that in your handouts? I don't think I had that in there originally. But when we look at fasting insulin based on the quartiles of periodontal disease, health, early, moderate, late, we see the fasting glucose going up in a fashion that we'd expect it to based on other research. And the insulin resistance, as measured here, also is in a linear fashion here based on the severity of periodontal disease. And so the results were that in no to mild periodontal disease, insulin resistant was really 0. But the relative risk for moderate to severe periodontitis among all age groups was 2.3-fold increase in insulin resistance. In fact, they said further that for every 1.04 millimeters of bone loss, insulin-resistant levels increased by 1.04 for every 1 millimeter periodontal disease attachment loss. Thus, these findings do support the role of inflammation as both a mediator and an effector of insulin resistance. The conclusion here positively associated the risk of elevating fasting insulin and insulin resistance in a dose-responsive fashion. In this particular study, they found that approximately 30% increased risk for insulin resistance across all periodontal disease quartiles. They also mentioned here that some studies are looking at specific bacteria, and they think that this study would have been better if they'd looked at specific bacteria, and hopefully they will go back and look at specific bacterial species. This study that was published in Diabetes Care in 2008 that relates to periodontal disease and incident type 2 diabetes looked at a very large group of 70 to 200 non-diabetic groups over 20 years, defined periodontal disease based on 6 categories based on periodontal disease index, and they looked at incident diabetes as defined by death certificate, self-reported diabetes, or healthcare facility stay with diabetes. And the conclusion was that individuals that had early to mild periodontal disease, that the odds ratios for type 2 diabetes was not elevated, but the odds ratios in periodontal index 3 through 6 showed that individuals that had periodontal disease certainly were increased risk for type 2 diabetes. This particular study, which is also brand new, was done in France. Although it's published in the Journal of Clinical Periodontology, it was first published in 2011 in a French medical journal. It was sponsored by the French Society of Cardiologists, and also sponsored by the University at Dijon and also another university. So this was a established medical study that was published there, and now it's published here in the Journal of Clinical Periodontology, and looked at periodontal disease as a new factor associated with the presence of multiple complex coronary lesions. So I thought this would be a good point to ask the question to our physician colleagues over here: what is the risk for a person that has multiple complex lesions as opposed to a person that has a single complex lesion? Would you all please comment on that? Kind of putting you on the spot here.
Yeah, no, multiple complex lesions certainly are more dangerous and overall going to result in more cardiovascular events.
This on. Okay, so that's true. I mean, it can implicate the severity and longevity of the disease, but at the same point, I just want to bring up that the smallest single isolated lesion can cause the biggest thrombus ever. So regardless, I mean, probably the multiple complex coronary lesion is just diagnosing the severity and the longevity that patient has had disease.
Okay, gotcha. Thank you for the input. The article went on to say also that these individuals, and you can either agree or disagree, that these individuals are at increased risk for another event occurring within the next 12 months, and maybe at an increased risk for dying during the first year because of the multiple lesion scenario here. And so they wanted to look at, and this is really an interesting study because it's the first time they looked at percent of bone loss as perhaps a predictor of multiple coronary lesions. And so they looked at 150 patients with recent heart attacks. These patients had been admitted for coronary rehab, and there was 118 patients in the single complex group, 32 patients in the multiple complex group. And of course they determined this by angiography, and they took panographic dental x-rays while they were going through cardiac rehab while they were in the hospital. And what they showed there was that there was an odds ratio of 3.52 if alveolar bone loss was greater than 50%. And what they also went on to say that this shows for the first time that bone loss could be a relevant and simple criteria to assess likelihood of multiple coronary lesions in patients with recent heart attacks. Interesting, because that's an easy thing for every one of us to do, is to look at panographic x-rays. Now, I show the clinical utility of this by showing you some cases that I've been asked to work with from either periodontists or oral surgeons or general dentists when we're having implant failure. So when you see these three implants tied together, would you say there's more than 50% bone loss? The point I'm simply making here, and this is the other side of the patient here, we've typically looked at periodontal disease from a microbiologic standpoint of view, and we should, because there's direct correlation between these microbes and this disease. And we should have known that before we placed the implant. So I think that we should stay right here, that if you're placing implants, and all of us are involved in some way in implant placement or restorative, that we should be using both tests. We should be using the interleukin-1 test to look for severity of infection, and we should be testing for pathogens. It is very well known the same microbes associated with periodontal disease are also associated with periimplantitis. So be sure to protect yourself, protect the patient, make sure that when you know the right time to place the implant and how to protect the implant, how to protect the patient. So we should be looking at tests like this. Here's another case right here where we were looking at, massive bone loss around implants. So what is the point here is we can use panographic x-rays to certainly evaluate bone loss, to look at dental health. We can use also panographic x-rays to look at potential for calcification in the artery system, and we can also look at pathogen tests, and we look at genetic tests. So we can use this model here for looking at certainly oral health, but potentially also systemic health or systemic disease as well. So periodontal therapy reduces systemic risk markers in coronary heart disease. And this is the last study before I'll go to my final presentation. You have some other slides in there that I'm not going to cover, and you can certainly read those. In this particular study, which was actually a study that was just published in Pakistan, and then it was sent to us, published through the Journal of Clinical Periodontology. And it looked at, is it possible that non-surgical periodontal therapy actually reduces coronary heart disease risk markers? And they again use simply scaling and root planing and hair and home care instructions, nothing else. And so then they looked at CRP, fibrinogen, and white blood cells in these coronary event patients. Looked at 285 patients. They're in the intervention. They purposely wanted a large number of intervention, about twice the number of controls, so they could really determine if intervention is working. And they looked at them at baseline, at 1 month, and at 2 months. And what they found was just by scaling and root planing, and by the way, we don't even know if that's effective or not, right? We don't even know if scaling and root planing is actually achieving an end result where we've actually reduced the disease. But yet, without any testing at all, if we do just that, the CRP was 30% decreased, and that is equivalent to the same response from statin therapy. The fibrinogen was reduced from 367 to 299, and white blood cells were reduced from 7.8 to 6.7. And when they looked at the controls, who were treated later, none of these levels changed. So 50% of them still had greater than 4 millimeters of pocketing.